In the final part of this lecture, we will talk about neuromuscular junction disorders. And in these disorders, there is a problem in the chemical synapse between the motor neuron and muscle fiber, and this is called the neuromuscular junction. There are a group of diseases which lead to weakness by affecting the transmission of nerve impulses from the distal part of the motor neuron to the muscle fiber. And these diseases will lead to lower motor neuron type of weakness because the condition is at the level of the lower motor neuron. Previously we said that in order for a muscle to move, a nerve impulse must be generated in the cerebral cortex in the motor areas, and then this impulse must be carried out through special pathway in order to reach eventually the muscle. The final pathway of these motor nerve impulses is in the neuromuscular junction. So sometimes the cause of weakness, specifically lower motor neuron weakness, can be due to disease involving the neuromuscular junction. Before we talk about these diseases, let's discuss the basic concept of neuromuscular junction. How does nerve impulse gets transmitted from the terminal part of the nerve to the muscle fiber, and how it will lead to muscle contraction? And then we will discuss all the diseases which involve the neuromuscular junction and how do these diseases affect this part of the motor system, at which level. First, the nerve action potential will arrive at the terminal part of the nerve fiber, and this will lead to depolarization. When the action potential arrives at the distal part of the nerve fiber, this will lead to depolarization in the membrane of the distal part of the nerve fiber, and this depolarization will activate voltage-gated calcium channels at this terminal part, and this will allow calcium influx. And this influx of calcium will trigger the release of neurotransmitter, which is already stored in vesicles in this terminal part of the nerve. In the terminal part of peripheral nerves, there are vesicles in which there is a neurotransmitter stored, and this neurotransmitter is acetylcholine neurotransmitter. This calcium, which enters the cell after the arrival of action potential in the terminal part of the cell, this calcium will allow the release of these neurotransmitters from the vesicles, and this acetylcholine will be released from the vesicles to be released outside the nerve terminal by exocytosis. And this acetylcholine will be released in a space between the terminal part of the nerve fiber and the muscle fiber. And this space is called synaptic cleft. This is a space in the neuromuscular junction between the terminal part of the nerve fiber and the muscle fiber, which is supplied by this nerve fiber. Then acetylcholine will act and will activate special receptors found on the muscle fiber. The muscle fiber at the neuromuscular junction is called postsynaptic membrane. This is postsynaptic membrane, and this is presynaptic membrane. If the nerve fiber is presynaptic membrane, while the muscle fiber is postsynaptic membrane. And acetylcholine, which is released from the presynaptic membrane, and from the terminal part of the nerve, will activate receptors found on the postsynaptic membrane and receptors found on the muscle fiber membrane. And these receptors are called acetylcholine receptors. As you can see, acetylcholine blue in color, while the receptors green in color. Acetylcholine will activate these receptors. Upon activation of these receptors, لما يحصل activation to these receptors by acetylcholine, this will lead to activation of sodium channels in the postsynaptic membrane, and this will allow sodium influx into the postsynaptic membrane and into the muscle fiber, and this influx of sodium will lead to depolarization and muscle action potential. And when there is muscle action potential, that means the muscle will contract and the muscle will move. This is simply how neuromuscular junction work. This is the way by which the nerve impulse, the motor nerve impulse, will leave the terminal part of the nerve and will reach the muscle fiber. And eventually this will lead to muscle action potential and muscle contraction. Interruption to any level of this pathway can lead to neuromuscular junction disease. For example, there is one disease which can block these receptors, اللي هي acetylcholine receptors. And by blocking these receptors, it prevents the binding of acetylcholine to its receptors. And this will lead to less activation of sodium channels, and that means less sodium influx, and that means less muscle action potential. And eventually هيكون في less muscle contraction, that means the muscle will be weak. فيبقى one disease can lead to weakness by blocking these acetylcholine receptors. And this disease is called Myasthenia Gravis. There's another disease, also another condition, which can also lead to weakness due to problem at the level of the neuromuscular junction by blocking these calcium channels here. Initially, we said when the action potential arrives at the terminal part of the nerve fiber, this will activate calcium channels. And these calcium channels, which is voltage-gated calcium channels, will allow the influx of calcium. And we said that in calcium, which enters, will lead to release of acetylcholine. If without calcium, there will be no acetylcholine release. If there is another disease which block these calcium channels. And by this way, it will not allow calcium influx, and this will not lead to acetylcholine release. And since there is no acetylcholine release, that means eventually there will be no muscle contraction. And this will lead to weakness. This condition is called Lambert Eaton syndrome. Lambert Eaton syndrome is a neuromuscular junction disorder والlevel of injury بيكون في الكالسيوم شانل في البري-سينابتيك، لأنه هنا الكالسيوم شانلز دي موجودة في البري-سينابتيك ممبرين. في البري-سينابتيك voltage-gated calcium channels بيكون في block in these channels. There is another condition, third condition, which also affect the neuromuscular junction by inhibiting the release of acetylcholine. يعني في الثيرد كونديشن ده الكالسيوم channels are intact، في calcium influx والacetylcholine receptors intact. The problem is in the release of acetylcholine. This condition inhibits the release of acetylcholine. Actually here toxins, neurotoxins, which will be released in the nerve, in the terminal part of the nerve, and it will inhibit the release of acetylcholine. وبالتالي لما يكون ما في acetylcholine release, this will lead to less generation of action potential in the muscle and less muscle contraction, and this will lead to weakness. This condition is botulism. Botulism is an infectious condition in which botulinum tetanae infection will release neurotoxins, and these neurotoxins will block and inhibit the release of acetylcholine from the presynaptic membrane, and this will lead to some sort of neuromuscular junction disorder. In this section, we will discuss the three conditions: Myasthenia Gravis, Lambert Eaton syndrome, and botulism. First, we will start with the most important neuromuscular junction disorder, which is Myasthenia Gravis. Myasthenia Gravis is a Latin term which means grave muscle weakness. Simply, it means grave muscle weakness. معناته في Myasthenia Gravis, the main problem is muscle weakness. And specifically in Myasthenia Gravis, there is an autoimmune disorder of the neuromuscular junction. And the autoimmune reaction is directed against these receptors, اللي هي acetylcholine receptors, leading to less or insufficient functioning acetylcholine receptors. Because these autoantibodies, which found in Myasthenia Gravis, will block these receptors, and at the same time, it will also Myasthenia Gravis is some sort of type 2 hypersensitivity reaction in which autoantibodies are reacting against self-antigens. self-antigens هي عبارة عن antigens fixed to the cells اللي هي عبارة عن receptors هنا. فthese antibodies will block these receptors، فبالتالي بيكون في less functioning receptors. بالتالي receptors which blocked by autoantibodies will not be activated by acetylcholine. But that means acetylcholine will find less available receptors at the postsynaptic membrane, and this will lead to muscle weakness. Also, these autoantibodies not only block these acetylcholine receptors, but it will also lead to activation of complement system. An activated complement will initiate an inflammatory reaction in the muscle fiber in the postsynaptic membrane, and this inflammatory reaction will lead to destruction and loss of more acetylcholine receptors. فبيبقى عندنا في deficiency and insufficient acetylcholine receptors due to block of these receptors by autoantibodies and due to reduction in the number of the receptors due to the inflammatory process which initiated by this autoimmune reaction. يبقى Myasthenia Gravis is type 2 hypersensitivity reaction. It's an autoimmune disease which is directed against acetylcholine receptors. When there is insufficient active acetylcholine receptors, that means there will be less activation of acetylcholine receptors by acetylcholine, and this will lead to less generation of action potential in the muscle, and that will lead to weakness eventually. The main feature of myasthenia gravis is weakness. Well, the type of weakness seen in myasthenia gravis is lower motor neuron type of weakness, and this is the same type of weakness seen with any neuromuscular junction disorder. Any disorder affecting the neuromuscular junction will lead to lower motor neuron weakness, not upper motor neuron weakness. This condition is more common in women with ratio of 2:1, and it has a characteristic bimodal distribution. Bimodal distribution, it means myasthenia gravis affect different age groups in females and different age groups in males. It's more common in females, but it still can affect males. In females, myasthenia gravis affect usually females at the age between 20 to 30 years old, young females. While in males, myasthenia gravis tend to affect older males between the age of 60 to 70 years. And this is called bimodal distribution. Myasthenia gravis is more common in women, like in women it affects young women between 20 to 30 years. While when it occurs in males, it will affect old males between the age of 60 to 70 years. The reason for that is unknown, but this is called bimodal distribution. This condition is associated with a lot of other conditions. It has association with thymoma, which is a tumor in the thymus gland in 15% of cases. It also has an association with thymic hyperplasia in 50 to 70% of cases. Probably this is because it's an autoimmune disease. Probably there are some T helper cells which found in the thymus, and these T helper cells will contribute to production of autoantibodies. T helper cells will stimulate the B cells to produce autoantibodies. That's why there is thymic hyperplasia in myasthenia gravis. But anyway, myasthenia gravis has been shown to be associated with thymoma, and more commonly with thymic hyperplasia in 50 to 70% of cases. Also, because it's an autoimmune disease, that means it can be associated with other autoimmune conditions, like autoimmune hypothyroid disease, for example, like pernicious anemia, or any autoimmune disease can be seen with myasthenia gravis as well. The key feature of myasthenia gravis is muscle fatigue, muscle fatigability, and weakness. We said myasthenia gravis means grave muscle weakness. The main feature is muscle weakness. Actually, sometimes it can be described as fatigability rather than weakness. And this fatigability and muscle weakness in myasthenia gravis, it tends to get worse at the end of the day. Because during the day, with continuous and repetitive use of muscles, this will lead to consumption of acetylcholine receptors. And during the day, while you are doing activities during the day, the acetylcholine released will act on the available acetylcholine receptors. Already بيكون في insufficient acetylcholine receptors. During the day, at the start of the day, while you are moving and walking around, acetylcholine will activate the available acetylcholine receptors. لكن as the time passes by, لما نصل لنهاية اليوم, there will be no enough acetylcholine receptors. بتكون الacetylcholine receptors saturated أو fully saturated. لأنه already في deficient receptors. والreceptors دي استهلكت خلال اليوم بالacetylcholine receptors with activity. فلما نصل لنهاية اليوم بيكون في less number of available active acetylcholine receptors. That means إنه الفatigue, muscle fatigue والmuscle weakness هيكون more pronounced and more severe at the end of the day. This is characteristic feature of myasthenia gravis. Also ممكن not at the end of the day, ممكن الفatigue والmuscle weakness to get worse with repetitive movements. Like مثلا chopping vegetables أو cutting vegetables in the kitchen. لما تكون بتقطع في vegetables, this is a repetitive movement. Initially ممكن to be able to do this movement normally. لكن with time لما تستمر for minutes chopping these vegetables, eventually you will start to feel fatigability in the hand muscles, weakness in hand muscles. This is because initially acetylcholine is activating the available acetylcholine receptors. لكن at some point هيكون في oversaturation, هيكون في saturation of the available acetylcholine receptors. لأنه already في limited number of available acetylcholine receptors, and these receptors will become activated, will become saturated. فما هيكون في enough acetylcholine receptors available eventually. That's why with repetitive movement can lead to worsening of muscle fatigability and muscle weakness. طيب this is the characteristic key feature in myasthenia gravis. A lot of muscles groups can be affected in myasthenia gravis, but most commonly a weakness and fatigue is seen more in the proximal muscles of the limbs, وتحديدا في ال proximal muscles of the upper limbs, يعني shoulder girdle muscles. Also, it can affect the muscles which supply by cranial nerves, اللي هي ال bulbar muscles. So it can lead to bulbar weakness, leading to bulbar palsy. A patient can have dysarthria, dysphagia, and nasal regurgitation. Also, it can lead to weakness of the facial muscles, muscles of facial expression, leading to bilateral facial weakness. Also, it can involve the ocular muscles, اللي هي ال extrinsic ocular muscles تحديدا, and that can lead to ptosis. إذا حصل weakness في levator palpebris superioris muscle which elevates the eyelid, this can lead to ptosis. And ptosis in myasthenia gravis ممكن يكون bilateral ptosis. Also ممكن يحصل weakness في extraocular muscles leading to diplopia. But these are the features seen with myasthenia gravis. But sometimes catastrophic complication of myasthenia gravis is respiratory muscle weakness. The same weakness and fatigue which occurs in other muscles can also seen in the respiratory muscles. And this can lead to serious complication leading to respiratory failure. The most serious complication of myasthenia gravis is involvement of the respiratory muscles leading to respiratory failure. The diagnosis of myasthenia gravis, the initial test, the best initial test in myasthenia gravis when you suspect myasthenia gravis is anti-acetylcholine antibodies test. We said that in pathology or pathophysiology of myasthenia gravis, there are autoantibodies directed against the acetylcholine receptors. So we can check these antibodies in the serum. It's called anti-acetylcholine antibodies test. And this test is found positive in 85 to 90% of cases. It's a highly sensitive test. In the remaining patients اللي هم بيكون يعني in 10% to 15%, those who not have anti-acetylcholine antibodies in their serum, they can have another type of antibodies, which is called anti-muscle specific tyrosine kinase antibody. This is another type of autoantibody which also can be seen in myasthenia gravis in 40% of cases. So if you suspect myasthenia gravis, initially we'll do this test. If this test is positive, then this is that means the patient is very likely to have myasthenia gravis. If this test is negative, you can do another autoantibody test, which is anti-muscle specific tyrosine kinase antibodies, which is also can be seen in 40% of myasthenia gravis cases. There is another test, old test used to diagnose myasthenia gravis, but nowadays it's obsolete. It's not used nowadays, which is called tensilon test. In this test, you will use a drug which is short-acting anticholinesterase drug called idrophonium. Normally, these acetylcholine, which release in the receptors and which release in the space between the presynaptic and postsynaptic membrane, اللي اسمه synaptic cleft, the acetylcholine there is an enzyme here also at this space called acetylcholinesterase. And this enzyme break down acetylcholine. It prevent يعني the over activation of these receptors by acetylcholine. يعني إذا ما كان في الانزيم ده كان ممكن الacetylcholine released here to over activate these receptors, leading to excessive activation of these receptors. And this will lead to weakness. This is an important point. Less activation, less than normal activation of acetylcholine receptors will lead to weakness. And this is what happens in myasthenia gravis. لكن at the same time, إذا كان في overactivation, overstimulation of these receptors, this will also lead to weakness. But due to that reason, there is an enzyme here called acetylcholinesterase, which will break down acetylcholine. And it will prevent overstimulation and overactivation of these receptors in order to prevent weakness. عشان يكون الactivation controlled. But this enzyme معناتها it will shorten the half-life of acetylcholine. فيبقى one way to diagnose acetylcholine is to give a drug which will block this enzyme اللي هو acetylcholinesterase. والدرug هيكون معناتها anti acetylcholinesterase drug أو acetylcholinesterase inhibitor drug. In this test we will use short acting. هنيجي نشوف الدراجز دي اللي هي acetylcholinesterase inhibitors فيها short acting وفيها long acting drugs. لكن the main point of this, the mechanism of action of these drugs is that they block this enzyme. They block acetylcholine esterase enzyme, فبالتالي they inhibit the breakdown of acetylcholine. That means إنه هيكون في more acetylcholine available here in this space. So that means there will be more activation of acetylcholine receptors. تبقى when you give a drug which will block this enzyme, that means you will provide the postsynaptic membrane with more concentration of acetylcholine. فdespite انه في المايثينيا جرافيس في less number of active acetylcholine receptors, لكن إذا بقى في more release of acetylcholine, this large concentration of acetylcholine can activate the pre-existing small number of acetylcholine receptors. This can lead to correction of the problem, and can lead to improvement in weakness. فبالتالي patient of myasthenia gravis who was having weakness initially ممكن to get improved after this test. هيحصل improvement للweakness لأنه هيكون في more acetylcholine activating acetylcholine receptors even لو إنه acetylcholine receptors يعني are deficient. This will lead to transient improvement in weakness. It's transient لأنه the drug is short acting. فبالتالي بتعمل transient improvement in weakness, and this will confirm the diagnosis of myasthenia gravis. فهنا أنت معناتها إنه البروبلم كانت في neuromuscular junction, and this problem has been reversed once you gave a drug which block the breakdown of acetylcholine. فبالتالي بيجي في more concentration of acetylcholine, and this has led to improvement in weakness. So when this test become positive, and the patient improves after this test, this can confirm the diagnosis of myasthenia gravis. لكن this test is dangerous because acetylcholines دي هي عبارة عن receptors of the parasympathetic nervous system in general. Sorry, acetylcholine هي عبارة عن neurotransmitters released by the parasympathetic nervous system in general. فالparasympathetic nervous system عنده receptors اسمها muscarinic receptors in which برضو acetylcholine بيشتغل فيها. اوكي، الacetylcholine بيشتغل في two types of receptors. في nicotinic receptors اللي هي دي receptors الموجوده في البوست سينابتيك membrane، ودي هي receptors عن طريقها بيحصل muscle contraction. لكن في another groups of receptors بيشتغل فيها acetylcholine, and these receptors are parasympathetic receptors called muscarinic receptors او cholinergic receptors يعني تعتبر. فالمسكرينيك ريسبتورز بيشتغل فيها الاسيتايلكولين موجوده في السايتس of parasympathetic nervous system actions، الحتات اللي بيشتغل فيها parasympathetic nervous system. مثلا في الساليفري glands، يعني parasympathetic nervous system stimulate the release of saliva from salivary gland، او مثلا في urinary bladder، في internal sphincters، في intestinal smooth muscles. فيبقى اما نزيد concentration of acetylcholine هنا، we will also increase the concentration of acetylcholine at the site of parasympathetic nervous system receptors اللي هي المسكرينيك receptors. فبالتالي هناك زي ما هنا هيكون في increased activity، هناك برضه هيكون في increased activity في parasympathetic receptors, and this will lead to يعني overactivation of parasympathetic nervous system. The patient can develop cholinergic side effects، بنسميها cholinergic side effects اللي هي side effects resulting from excessive acetylcholine action. والcholinergic side effects ممكن تكون hypersalivation، ممكن تكون in form of urinary incontinence، ممكن تكون in form of diarrhea، ممكن to lead to meiosis. And there are other features, other cholinergic features, and these cholinergic features are dangerous لأنه sometimes even might be associated with bradycardia، لأنه برضو parasympathetic nervous system بيشتغل في ال SA node وال AV node. فبالتالي لما يكون في too much activity of parasympathetic nervous system in the heart, this will lead to bradycardia. This is serious. That's why this test is dangerous, because although it improves the weakness, like at the same time it will lead to cholinergic side effects due to concentration of acetylcholine هتكون برضو high في المسكرينيك receptors، لأنه الacetylcholine again عنده cholinergic receptors. الريسبتورز بيشتغل فيها الacetylcholine بيسموها cholinergic receptors. الcholinergic receptors هم two types، في nicotinic receptors دي هي الموجودة هنا، وفي muscarinic receptors. المسكرينيك receptors دي هي الريسبتورز اللي بيشتغل فيها الacetylcholine at the site of parasympathetic nervous system activity. يعني المسكرين receptors دي هي receptors بتاعت parasympathetic nervous system وبيشتغل فيها acetylcholine برضه. the same enzyme which blocked here, it will be blocked there in the muscarinic receptors. فمعناتها concentration of acetylcholine not only will be high here, but it will be also high in the muscarinic receptors, leading to more parasympathetic activity. and this will lead to cholinergic side effects. يبقى this test, that's why it's contraindicated nowadays. It's not advised to be done because it's associated with serious cholinergic side effects, وتحديدا احنا بنخاف من البراديكارديا. لكن في other cholinergic side effects زي الديارية وزي الانكونتيننس والهايبرسلايفيشن والميوزس وفي other features. الفيتشرز دي كلها related to parasympathetic overactivity. The most accurate test to diagnose myasthenia gravis is single fiber electromyography, single fiber EMG. EMG وتحديدا في ال EMG بنعمل specific test اسمه single fiber EMG. This test is the gold standard test to diagnose myasthenia gravis. It has high sensitivity, 92 to 100% to diagnose myasthenia gravis. A characteristic finding in this test is a decremental decrease in muscle fiber contraction or repetitive nerve stimulation. الفكرة بتاعت التست إنه you test a single fiber of muscle and you will repetitively stimulate the nerve which supplies this single fiber. أما تعمل repetitive stimulation to the nerve، يعني مثلا إذا قلنا ده nerve ending وده muscle fiber، أما تعمل repetitive stimulation to this nerve that means إنه هيحصل more action potential here. فيه هيكون more depolarization، بالتالي more calcium influx here, and this will lead to more release of acetylcholine, and this will lead to activation of these receptors and muscle contraction. فالrepetitive nerve stimulation أما نعمله في myasthenia gravis ممكن initially يكون عمل لنا muscle contraction، لأنه by this depolarization هيحصل release of acetylcholine and this will activate the acetylcholine receptors. لكن actually what happens إنه بيحصل decremental response. Decremental يعني تنازلي، يعني muscle contraction هيبدأ ينقص تدريجيا. And this is the same way as we discussed here. We said that at the end of the day بيحصل muscle fatigue، وقلنا مع repetitive movement بيحصل muscle fatigue. In the same way أنت لما تعمل repetitive stimulation للnerve which supply the muscle, this can eventually lead to fatigue of the muscle. لأنه إحنا قلنا initial acetylcholine it will activate the available acetylcholine receptors and this will lead to saturation of the receptors. فبالتالي بعد eventually ما هيكون في available receptors for acetylcholine. فعشان كده الكونديشن هيكون decremental، هيكون المسل weakness المسل contraction تنازليا، هينقص تنازليا، هيكون في less contraction مع الستيميوليشن، مع repetitive stimulation. This is called decremental decrease in muscle fiber contraction or repetitive nerve stimulation. This characteristic feature of myasthenia gravis. لأنه normally في normal situations أنت لما تعمل repetitive stimulation للnerve fiber which supply the muscle المفروض إنه الكونتراكشن يزيد، المفروض يكون في incremental response. incremental يعني تصاعدي، contraction يزيد، لأنه more depolarization معناتها more release of acetylcholine و more activation of these receptors وبالتالي more muscle contraction. لكن هنا في المياسثينيا gravis في عندنا limited number of acetylcholine receptors، فبالتالي it will be saturated very fast. eventually هيحصل decremental response، بدل ما يزيد الكونتراكشن هينقص الكونتراكشن تدريجيا. And this is characteristic of myasthenia gravis seen in single fiber EMG tests. Another test which can be also done in myasthenia gravis is chest imaging, chest X-ray and chest CT, because we said myasthenia gravis is associated with thymoma and thymic hyperplasia. So we can detect these two disorders by doing chest CT, for example. And this can give a clue towards myasthenia gravis. Creatine kinase, it's an enzyme which is present inside the muscles. Creatine kinase is usually released in inflammatory myopathies. أما يكون the cause of muscle weakness is inflammatory myopathy مع polymyositis for example. In that cases there will be release of creatine kinase into the blood. لكن هنا the cause is not inflammatory myopathy. The cause is neuromuscular junction disorder. فcreatine kinase بالتست بيكون normal in myasthenia gravis. This test is just to differentiate between a neuromuscular junction disorder and muscular disorders، لأنه مرات بيكون بتشابهوا في clinical presentation. ممكن يكون الماسكولار disorders زي الماسكولار dystrophies والinflammatory myopathies to mimic الفيتشرز تحت neuromuscular junction disorder. And this test can help you differentiate between the two conditions. في الماسكولار disorders دائما بيكون CK high، لكن في neuromuscular junction disorder بيكون normal. طيب نجي للمانجمنت of myasthenia gravis. المانجمنت فيه 3 main parts. في long acting acetylcholine esterase inhibitors اللي هي دي drugs زي الدراج اللي استخدمناه هنا في التنسلون تيست. هنا لكن استخدمنا short acting drug. لكن here we use long-acting drug. Long-acting acetylcholine esterase inhibitors. In the same way, these drugs will inhibit the acetylcholine esterase اللي هو الانزيم اللي قلنا موجود هنا وبيعمل break down للacetylcholine فبالتالي بتقلل الهاف لايف of acetylcholine. يبقى when you block these enzymes, the acetylcholine esterase, by giving a drug which is called anti-acetylcholine esterase inhibitor, you will prolong the half life of acetylcholine. معناتها هيكون في more acetylcholine available here at this receptor. This will improve the muscle contraction, will improve the weakness. But this is the main drug used, the main class of drugs used in the management of myasthenia gravis. Example is pyridostigmine and neostigmine. لكن the problem with these drugs إنه they can also lead to cholinergic side effects as we discussed here. The same thing. لكن هنا cholinergic side effects is worse لأنه drug is short acting فممكن تكون severe cholinergic side effect. هناك cholinergic side effects ممكن تكون less severe لكن still it can happen. Because in the same thing we said that إنه الacetylcholine بيشتغل في two receptors ما بس الريسبتورز هنا لكن عنده receptors اللي هي muscarinic receptors which mediate the parasympathetic nervous system activity. فبالتالي ممكن these drugs to lead to parasympathetic overactivity side effects اللي هي بنسميها cholinergic side effects. And these side effects include diarrhea, include bradycardia, include hypersalivation, include urination, excessive urination, urinary incontinence, and there are meiosis, and there are other features as well. These are the feared complication. Along with that, we also said إنه when these receptors are less يعني لما يكون في deficiency in acetylcholine receptors, this will lead to weakness. وده اللي بيحصل في myasthenia gravis. لكن at the same time قلنا لما يكون في more activation of these receptors, this can also lead to weakness. يعني لما يكون في under activation or under stimulation of acetylcholine receptors as seen with myasthenia gravis, this will lead to weakness. لكن at the same time لما يكون في over stimulation of acetylcholine receptors, this can also lead to weakness. And this is paradoxical يعني concept. فيبقى نحن لما ندي anti acetylcholine esterase drug هنا معناتها هنزيد concentration of acetylcholine receptor acetylcholine level here. فلما يكون في more acetylcholine available here at the neuromuscular junction ممكن يكون في over stimulation of acetylcholine receptors even though أصلا في limited number في myasthenia gravis لكن still sometimes ممكن الدراجز دي تكون so potent لدرجة إنها تعمل over stimulation للacetylcholine receptors. And this overstimulation of acetylcholine receptors will also lead to weakness. And this is called cholinergic crisis. Cholinergic crisis is a severe form of cholinergic side effects. اللي هي side effects resulting from excessive acetylcholine action. وتحديدا acetylcholine action في الريسبتورز دي. It can lead to weakness, muscle weakness. فيبقى these drugs, although it's used to relieve and to improve a weakness in myasthenia gravis, لكن sometimes these drugs can even lead to worsening of weakness. Sometimes, not all the way. لكن in most of the cases, these drugs are good in controlling a weakness. لكن if for example, the patient received high doses of this drug, this can lead, this overdose of drug, this can lead to cholinergic crisis, which will lead to weakness of the muscles. This is a very important point. Another class of drugs which also used in the management of myasthenia gravis is immunosuppressive drugs. Immunosuppressive drugs include steroids. وsteroids تحديدا prednisolone is used in cases refractory to these drugs. يعني first line treatment for myasthenia gravis is long-acting acetylcholine esterase inhibitors. لكن if these drugs fail to control the condition, the second line will be steroids, will be prednisolone, long-term prednisolone therapy. Or prednisolone and steroids can also be used in severe weakness. Sometimes the patient جاي initial severe weakness ممكن these drugs تكون يعني الاكتيفيتي بتاعتها slow فبنحتاج حاجه تكون more potent فبندي steroids اذا كان البيشنت جاي severe weakness because steroids are immunosuppressive drugs and the condition here myasthenia gravis is autoimmune mediated condition. by blocking the hypersensitivity يعني steroids will reduce the hypersensitivity reaction and this will improve the condition. طيب other than steroids في other immunosuppressive drugs can be used زي الازاثيوبرين والمايكوفينولate. And azathiopurine and mycophenolate, these are potent immunosuppressive drugs. They have also a lot of side effects. لكن احنا we use azathiopurine and mycophenolate as steroid sparing agents. steroid sparing agents بمعنى انه we use these drugs when the patient requires high doses of steroids. مرات لما نلقى patient of myasthenia gravis not controlled on small doses of steroids بيحتاج high doses of steroids. وطبعا احنا عارفين ان الستيرويدز كل ما زدنا الجرعه كل ما ال possibility of side effects بتزيد، بيكون في more side effects. فدايما احنا we don't prefer ان احنا نوصل الستيرويدز ل high doses. فلما ال patient of myasthenia gravis يصل ل point يحتاج فيها high dose of steroid, one strategy is to add another immunosuppressive drug اللي هو بنعتبره steroid sparing agent زي الازاثيوبرين. And this will allows us to reduce the dose of steroid. يعني احنا لما ندي الازاثيوبرين هيدينا immunosuppressive effect وهيعمل لنا كنترول. فممكن لما ندخل الازاثيوبرين نقدر ننقص الدوز اوف ستيرويد. فكده هنكون البيشنت يكون عنده combination of steroid مع ازاثيوبرين. لكن الازاثيوبرين اللي دخلناه ده will help us to reduce the steroid dose وبالتالي نقلل السايد effects which can result from steroid. دي هي الفكره بتاعت الستيرويد sparing agent. لما نقول steroid sparing agent معناته هو immunosuppressive drug used in order to minimize and to reduce the dose of steroid to prevent the side effects which can be seen with increasing the dose of steroids. طيب في important point regarding steroids. Steroids also can lead to worsening of weakness. زي ما الفيرست drug the class of drugs they بيعمل worsening of weakness، هنا برضه الsteroids can worsen the weakness in myasthenia gravis. And the reason for that because الستيرويد هو عباره عن synthetic glucocorticoid. يعني احنا الستيرويدز عموما البريدنيسولون تحديدا عنده glucocorticoidal activity. نحن بنعتمد على الجلوكوكورتيكويد activity اللي هي الاميونوسبريسيف، يعني من الجلوكوكورتيكويد اكشنز الاميونوسبريشن. لما نقول جلوكوكورتيكويد activity مقصود بها كورتيزول لايك activity. فالستيرويدز كل الستيرويدز عندها كورتيزول لايك activity. من الكورتيزول activity ومن الفسيولوجيكال functions of cortisol that we discussed previously in endocrinology, we said that cortisol increases protein breakdown. It's a catabolic hormone which increases the breakdown of protein. فبالتالي it can lead to breakdown of protein in muscles. وقلنا حتى even في الهايبركورتيزوليزم بيكون في myopathy due to breakdown of protein. فin the same way لما ندي steroid to patient of myasthenia gravis especially إذا ادينا high dose أو حتى without high dose، يعني مع التايتريشن إذا عملنا rapid titration زدنا الدوز بتاعت الستيرويد سريع، هنا ممكن الإفكت of الستيرويد on protein catabolism يكون higher، فبالتالي يكون في more breakdown of protein in the muscles. والmuscle already weak في myasthenia gravis، فلما يحصل breakdown in protein this will lead to more weakness in the muscles. فيبقى this is how steroids can worsen weakness in myasthenia gravis. So due to that reason, there are two recommendations in the management of myasthenia gravis. When you start steroid, you should slowly titrate the dose. يعني لما نزيد الدوز تحت الستيرويد البيشنت غالبا will not be controlled on small dose. يعني مثلا لو بدينا ب 5 ملغ او 10 ملغ هنزيد تدريجيا لحد ما نصل higher doses. التايتريشن ده should be slowly، ما يكون كل يومين. ندي gap ممكن week even 1 week gap between every dose and dose titration. فيبقى المفروض يكون في slow titration to the dose. This is number one recommendation. Number two recommendation, when you initiate steroid therapy in myasthenia gravis, this should be inside the hospital, should be in inpatient settings. يعني لما تكون عندك patient of myasthenia gravis and you want to start steroid therapy ما هتكتب له steroid therapy وهترسله البيت. You have to admit this patient in the hospital and you observe this patient. لأنه ممكن once you start steroid therapy يحصل worsening the weakness. ونحن ما بنخاف من الويكنس اللي بيحصل في البروكسيمال ماسلز ولا في الماسلز بتاعت الليمبس، نحن بنخاف من الويكنس اللي بيحصل في الريسبيراتوري ماسلز. لما يحصل worsening للويكنس في myasthenia gravis ممكن يكون in form of respiratory muscle weakness and this leads to respiratory failure and this is catastrophic. فيبقى when you start steroid therapy for myasthenia gravis patient you must admit the patient to observe for any paradoxical effect of steroid، يعني any worsening of weakness. These are the two important recommendations regarding steroid therapy in myasthenia gravis. طيب نشوف الرول of surgery in myasthenia gravis. We said that إنه myasthenia gravis is associated with thymoma and thymic hyperplasia. And this is the rule of surgery. In thymic hyperplasia, it was found in the removal of the thymus gland, يعني نعمل thymic resection. This will improve the features of myasthenia gravis. لأنه as I said previously قلت ممكن يكون في T helper cells طالع من الثايمس and these T helper cells stimulating B cells to produce antibodies. وبالتالي contributing معناتها الثايمس هنا contributing in the pathogenesis of myasthenia gravis. فلقوا إنه when you do resection to the thymus gland إذا كان في thymic hyperplasia تحديدا في المايليثينيا جرافيس this will improve the symptoms of myasthenia gravis. لكن إذا كان في ثايموما even إذا عملت resection للجلاند والتيومر this will not improve the symptoms. لكن still نحن بنعمل برضه resection في حالة الثايموما. And this is not to improve الريسكشن here في الثايموما not to improve السيمبتومز بتاعت المايليثينيا جرافيس لكن to prevent malignant transformation. يعني في possibility إنه الثايموما دي benign حاليا ممكن to convert into malignant tumor. That's why we will do thymectomy in both cases. في thymic hyperplasia we will do thymectomy لأنه it has been proved يعني it has been shown to improve symptoms. في الثايموما it will not improve symptoms لكن we will do thymectomy to prevent a future malignant transformation of this tumor. فيبقى this is the rule of surgery in myasthenia gravis. هنا في another important point في drugs which can exacerbate myasthenia gravis يعني can worsen the weakness. Already number one the drugs دي despite إنه these drugs control the weakness لكن sometimes in higher doses in overdoses ممكن to lead to weakness. والsteroids برضو can lead to weakness قلنا especially لما نحصل rapid titration of steroids. لكن في other drugs تانية اللي هي includes antibiotics like aminoglycosides. Aminoglycosides اللي هي زي gentamicin. Gentamicin is a classical antibiotic which can worsen myasthenia gravis. عشان كده احنا دايما ما بندي gentamicin لمyasthenia gravis patient. Also quinolones. Quinolones class of antibiotics اللي هي زي السيبروفلوكساسين والموكسيفلوكساسين والليفوفلوكساسين دي هي quinolones. These are widely used drugs. Again, these drugs can worsen weakness in myasthenia gravis. Another also group of drugs هي antihypertensive drugs زي البيتا blockers والverapamil. Beta blockers one of the common side effects of beta blockers fatigue. ونحن كلامنا قلنا في myasthenia gravis the main problem is fatigue. ممكن يكون ما في weakness يعني يكون mainly fatigue presentation muscle fatigue rather than weakness. فبيتا blockers contraindicated برضو in myasthenia gravis. Another class of drug الانتي-arrhythmic drugs تحديدا البروكاناميد اللي هو class 1A anti-arrhythmic drug والquinidine. These also an anti-arrhythmic. These are two anti-arrhythmic drugs هم عبارة عن class 1 anti-arrhythmic drugs sodium channel blockers. These are also exacerbating weakness in myasthenia gravis. Anti-epileptic drugs تحديدا الفينيتوين برضو والبنسلامين one of the old drugs used in the management of rheumatoid arthritis. Chloroquine, old anti-malarial drugs, والlithium. All these drugs can exacerbate myasthenia gravis. So these drugs should be avoided in any myasthenia gravis patient. An alternative should be used. The last part of the myasthenia gravis section is myasthenic crisis. The last point I would like to talk about is myasthenic crisis. Myasthenic crisis is an exacerbation, is an acute exacerbation of myasthenia gravis. احنا قلنا المين بروبلم في myasthenia gravis is weakness. اما نحصل myasthenia crisis بيكون في exacerbation of weakness. بيكون في severe weakness. And this weakness can involve the respiratory muscles leading to respiratory failure. This is the feared complication في myasthenia crisis اللي هي respiratory failure. ودائما myasthenia crisis بتحصل إذا كان في intercurrent illness. إذا كان patient suffering from any intercurrent illness, any stressful condition. Patient عنده intercurrent infection, trauma, any intercurrent illness can lead to precipitation of myasthenic crisis in myasthenia gravis patient اللي هو هيحصل worsening of weakness. طيب, how to manage this condition in myasthenic crisis? First of all, the patient should be admitted in ICU. This is definitely because the patient at risk of respiratory failure at any moment the patient might require mechanical ventilation. If the myasthenic crisis patient should be admitted in ICU. The second thing, the patient might require mechanical ventilation, might require ventilatory support. إذا كان في أي evidence of respiratory muscles fatigue and respiratory muscles weakness. وهنا في important parameter that should be monitored in any myasthenia crisis patient اللي هو forced vital capacity FVC. زي ما قلنا في الجيان-باري syndrome we monitor the pulmonary functions عن طريق ال FVC. Also here we should monitor ال FVC in myasthenic crisis to monitor the respiratory functions عشان at any moment if the patient عنده deterioration in the respiratory functions the patient might require ventilatory support. يبقى FVC monitoring is an important part of the management of myasthenic crisis patient. Also in myasthenic crisis we will give IV immunoglobulin or plasmapheresis ودول هم the two options of treatment used in Guillain-Barré syndrome. يعني myasthenic crisis ممكن نعتبرها زي ال Guillain-Barré syndrome because it's an acute condition برضه. يبقى ال option of treatment include IV immunoglobulin or plasmapheresis اللي هي plasma exchange. طيب another important point in the management of myasthenic crisis is you should stop the long-acting acetylcholine receptors inhibitors if it was used by the patient. يعني البيشنت غالبا هيجي بمyasthenic crisis هيكون already diagnosed with myasthenia gravis، ممكن يكون on one of these drugs، يا اما pyridostigmine او neostigmine او any drug يعني from this class. In myasthenic crisis you should stop this drug. This is controversial. I know these drugs will improve the weakness. Why do we stop these drugs? We stop these drugs actually because at the time of presentation of the patient we cannot differentiate هل الويكنس اللي جايبه البيشنت ده exacerbation of weakness ده due to myasthenic crisis ولا due to cholinergic crisis which is a side effect of this drug. يعني ممكن يكون الويكنس وحتى الريسبيراتوري باراليسيس ده ما يكون due to myasthenia gravis، يكون due to a side effect of these drugs. لأنه قلنا these drugs can lead to cholinergic crisis. فيبقى في كل الأحوال we have to stop this drug إذا البيشنت جاي myasthenic crisis عشان to eliminate the possibility of cholinergic crisis لحد ما البيشنت يبقى improved بعدين ممكن to reintroduce this drug. This is an important and crucial point in the management of myasthenic crisis. You should always stop acetylcholine esterase inhibitors. Another important point I would like to mention also regarding a clinical finding or physical findings in myasthenia gravis, although it's associated with lower motor neuron weakness, لكن there is no hyporeflexia. This is a characteristic point. في myasthenia gravis الرeflexes بيكون intact، ما بيكون في hyporeflexia. Although in the weakness lower motor neuron type of weakness. نجي ل another neuromuscular junction disorder which is Lambert Eaton syndrome. This condition is a disorder of neuromuscular junction. وهنا we discussed انه الديفكت is in the calcium channels في voltage gated calcium channels which found in the presynaptic membrane. فبيحصل بيكون في inhibition of these calcium channels، فبالتالي بيكون في less calcium influx and that will lead to less release of acetylcholine. طيب in this condition there is an autoimmune disorder as well similar to myasthenia gravis. An autoimmune disorder of the neuromuscular junction بيكون في defective acetylcholine release at the neuromuscular junction due to autoantibodies directed against voltage-gated calcium channels on the presynaptic membrane. يبقى هنا الانتيبوديز directed against voltage-gated calcium channels في presynaptic membrane. عكس المyasthenia gravis هناك directed against acetylcholine receptors on the postsynaptic membrane. هنا الديفكت في presynaptic membrane يعني في النيرف ما في المسل فايبر. Okay. طيب الموست common scenario الموست common form of LES is انه بيكون paraneoplastic syndrome، بيكون بيكون some form of paraneoplastic syndrome associated with small cell lung cancer. يعني دايما this autoimmune disorder بتكون associated with small cell lung cancer، يعني بتكون paraneoplastic syndrome تحديدا مع small cell lung cancer. ده in most of the cases of Lambert Eaton syndrome. لكن in minority of cases sometimes ممكن this condition to develop without an association with malignancy, without يعني association with small cell lung cancer. تكون simple autoimmune disease. وممكن هي تكون associated with other autoimmune disorders like hypothyroidism, like pernicious anemia, like even adrenal insufficiency. Any autoimmune disorder can be seen. لكن most common scenario إنه this disorder is a paraneoplastic syndrome associated with small cell lung cancer. طيب الكلينيكال بيكتشر او كلينيكال فيتشرز هي لامبرت ايتون ممكن تكون تشبه الفيتشرز بتاعت المايسينيا جرافيس to some extent. Here also there is weakness وفاتيج، والويكنس دايما بيكون برضه في البروكسيمال ماسلز. لكن here البروكسيمال ماسلز الانفولف دايما بيكون اللور ليمز بروكسيمال ماسلز. في المايسينيا جرافيس قلنا دايما الابر ليمز بروكسيمال ماسلز، لكن هنا في LES more commonly it affects the proximal muscles in the lower limbs. ده أول فرق. The second point إنه هنا البلبر weakness والfacial weakness والweakness of the eye muscles extraocular muscles is less common in Lambert Eaton syndrome compared to myasthenia gravis. يعني دايما لما نيجي البيشنت بتوزس وبلبر palsy it's more likely إنه تكون myasthenia gravis not Lambert Eaton. It's rare to see bulbar weakness and facial weakness and weakness in general weakness of muscle supply by the cranial nerves. It's rare in Lambert Eaton syndrome. Another also important point to differentiate between the two conditions, in Lambert Eaton syndrome there is hyporeflexia. احنا في المايثينيا جرافيس قلنا ما بيكون في hyporeflexia، لكن هير بيكون في hyporeflexia. In general اما تكون الديفكت في النيوروماسكولار جانكشن، اما تكون الديفكت في البوست ممبرين ما بيكون في hyporeflexia، لكن لما تكون البروبلم في البري ممبرين بيكون في hyporeflexia. فيبقى عنه Lambert Eaton is presynaptic membrane disorder, it will be associated with hyporeflexia. Along with that مع اللامبرت ايتون ممكن يكون في features of autonomic dysfunction, autonomic nervous system dysfunction، نفس الفيتشرز اللي شفناها في الجيان باري syndrome. ممكن يكون في bradycardia، ممكن يكون في tachycardia، ممكن يكون في postural hypotension، ممكن يكون في hypersalivation أو dry mouth، diarrhea, constipation, depending on which part of the autonomic nervous system is impaired. هل sympathetic dysfunction in the sympathetic nervous system ولا dysfunction في parasympathetic nervous system. فبكون في features related to autonomic instability with Lambert Eaton syndrome. لكن features of autonomic instability will not be seen with Myasthenia Gravis. And this is an important crucial point to differentiate between these two conditions. اللي هي autonomic dysfunction features. طيب the diagnosis of this condition also will do the same test اللي هو single fiber EMG. بنعمل برضه repetitive nerve stimulation خلال التست بتاعنا ده. هنا بيكون في عكس، هنا كان في decremental response، بيكون يعني الكونتراكشن بيقل مع repetitive stimulation. هنا العكس، هنا بيحصل improvement للكونتراكشن، الكونتراكشن بيزيد، contraction of the muscle will increase with repetitive nerve stimulation. لأنه كل ما حصل nerve stimulation هنا despite انه في انتي بوديز عامله بلوك لذيس كالسيوم شانلز، لكن في كالسيوم شانلز هتكون انتاكت. فلما يكون في repetitive stimulation للنيرف terminal, this will lead to activation of a pre-existing calcium channels. يعني calcium channels اللي بتكون not blocked by antibodies, it will be more active, it will lead to more calcium influx. فهيكون في more calcium influx despite انه في block ل some of the calcium channels، لكن في some calcium channels intact، والintact calcium channels هتكون more active لما يكون في repetitive stimulation. So that means انه هيكون في more release of acetylcholine and this will lead to more action potential, more muscle active potential، بالتالي it will improve the muscle contraction. هنا ما هيحصل decremental response لانه الريسبتورز intact، الريسبتورز not deficient، عندنا enough acetylcholine receptors. فبالتالي الريليز acetylcholine هتشتغل في تلقى available receptors تشتغل فيها، ما زي في المايثينيا جرافيس بيكون في limited receptors. عشان كده بيكون في decremental response في المايثينيا جرافيس، لكن هنا في اللامبرت ايتون بيكون في incremental او response او improvement بيحصل في contraction. And this is characteristic finding in Lambert Eaton syndrome. Along with that we can also test for antibodies. زي ما هناك شفنا antibodies في المايثينيا جرافيس، هنا برضه في antibodies against قلنا الكالسيوم الفولتج جيتد كالسيوم channels. فبالتالي we can check voltage gated calcium channels autoantibodies in the serum, and these are found in 90% of cases, which can also help in the diagnosis of this condition. Also we can do chest imaging to look for evidence of lung cancer, and when it's associated with small cell lung cancer. The treatment of this condition is there is a drug which is developed called 3,4-diaminopyridine (OAP). This drug has been shown to be safe and effective in the management of Lambert Eaton syndrome. Then you choose the last neuromuscular junction disorder, which is botulism. Botulism is an infectious disorder caused by Botulinum tetani infection. And this infection, this bacteria releases neurotoxins, and these neurotoxins will lead to neuromuscular block. How to acquire these neurotoxins? Normally these neurotoxins and this bacteria multiply in canned and bottled food stuff. يعني الأكل المعلب والمخزن دائما بيكون ممكن يكون فيه botulism neurotoxins، بيكون فيه botulism bacteria, Botulinum tetani bacteria, and the bacteria will multiply and will release neurotoxins in the bottled and canned food. فبالتالي source of this infection ممكن يكون من bottled food stuff، لكن although it's rare. Another source of this infection is through contamination of contaminated wound, especially in IV drug users. ممكن الwound to be contaminated with botulinum neurotoxins. But anyway, these neurotoxins, it will enter the nerve fibers, and at the distal part of the nerve terminal, the distal part of the nerve fiber and the terminal part of the nerve fiber, it will inhibit the release of acetylcholine. وبالتالي لما يكون ما في release of acetylcholine, this will lead to less muscle action potential and less muscle contraction, and this will lead to weakness. A characteristic pattern of weakness in botulism, usually there is descending paralysis. There is bilateral symmetrical descending paralysis. عكس الجيان-باري syndrome. الجيان-باري syndrome ده ascending bilateral paralysis وبكون flaccid paralysis. في البوتوليزم برضه بيكون في flaccid paralysis لكن بيكون descending وsymmetrical يعني bilateral paralysis. يعني similar to Miller-Fisher variant of Guillain-Barré syndrome as we discussed previously. Along with that, it's characterized also by bilateral cranial nerve pulses. يعني there is bilateral weakness in the muscles supplied by the cranial nerve. They are bulbar muscles, وبالتالي it can lead to bulbar palsy. Also, it can lead to bilateral facial weakness. We mentioned botulism as a differential diagnosis of bilateral facial weakness. ممكن to lead to bilateral ptosis, for example. فيبقى characteristic features are bilateral cranial nerve pulses associated with symmetrical descending flaccid paralysis. Also, it can involve the respiratory muscles, and this is the serious complication because it can lead to respiratory failure in the same way as in myasthenia crisis, in the same way as in Guillain-Barré syndrome. This is the feared complication which will require ventilatory support. Also, it's associated with autonomic dysfunction, and this also can help you to differentiate between botulism and myasthenia gravis. هنا there is autonomic dysfunction. فممكن يكون في features زي الفيتشرز برضه في Lambert Eaton syndrome. ممكن يكون في posture hypotension، ممكن يكون في tachycardia، ممكن يكون في bradycardia، ممكن يكون في diarrhea or any features related to autonomic dysfunction. Also, similar features can be seen in Guillain-Barré syndrome. يبقى botulism it can mimic Guillain-Barré syndrome، بس الفرق انه في Guillain-Barré syndrome الباراليسيس طالع فوق ascending، في البوتوليزم الباراليسيس descending. ودائما في البوتوليزم بنلقى في cranial nerve pulses، بنلقى في bilateral cranial nerve pulses، لانه ما دام هيبقى descending معناتها هيبدا من فوق من المسلز of the head and neck usually. طبعا no specific test to diagnose the condition. والtreatment usually no specific treatment as well. يعني دائما supportive treatment. The patient should be monitored. The FVC should be monitored to detect any respiratory muscle weakness. The patient might require ICU management at any point is a big respiratory muscle weakness, and the patient might need ventilatory support. في antitoxins, drugs antitoxins which antagonize and inhibit the action of the neurotoxins. لكن these drugs has been associated with anaphylactic reaction. فعشان كده are not widely used. تبقى management of botulism is mainly supportive management.